Can you get me? Okay, cool. So let's look at this question that you've brought. A 75-year-old male presents with a 1 month history of severe abdominal and epigastric pain. He states that the pain improves with meals but worsens approximately 1 hour after eating. He has a history of osteoarthritis, which he treats with NSAIDs. He has increased his dose for the past 3 months due to increased pain. Vital signs are stable and within normal limits. What is the diagnosis? And of course, here we've been told it's a PUD, a peptic ulcer disease. Of course, it's true, but let's just do some justice to the diagnosis, looking at the amount of marks that were being given. So, what do we know about this? We have severe abdominal and epigastric pain, and then we've also been told that the pain improves with meals, but then it worsens approximately an hour after eating. We've also been told he has a condition, osteoarthritis in this case, which he has been treating with NSAIDs, and he has increased the dose for 3 months. His vitals are stable. Okay, so we know that this is a PUD, but whether you'll be looking at the patient in person or a question that you've been given, apart from diagnosing that it's a PUD, you also kind of want to, you know, look at where potentially this PUD might be. Either it's in the stomach or it's in the duodenum. Either it's gastric or duodenal ulcer. So the way you can tell that will be from the history, especially surrounding the feeding patterns and what the patient notices happens whenever the patient takes a meal. So if we are to look at a basic stomach, the lower part of the stomach has a lower pyloric sphincter, and we know that the stomach is an acidic environment due to the amount of hydrochloric acid that's the present in the stomach, helping with digestion, helping with killing of pathogens and the like. So think of it in this way. Remember growing up, Akari, when say you have a wound and then someone decides to pour salt over that wound, that feeling, the way it would hurt. Anything salt, methylated spirit, when it's poured on that wound, it used to hit. So think of an ulcer in the stomach and the duodenum in the same way. Here we're dealing with hydrochloric acid. So either this ulcer is in the stomach or it's in the duodenum. So I want you to picture the same ulcer thing that I just spoke of. So when feeding begins, this lower pyloric sphincter closes, and remember that this is acidic. This environment is acidic. The duodenum is basic. That neutralization happens and so forth and so on. So feeding happens. Even the amount of hydrochloric acid that's secreted slightly increases. And remember, this is the stomach is lined by a layer of mucus around it, including the duodenum. So just think of some a mucus layer that's around it, and you happen to have an erosion. In this case, as an ulcer. The acid landing on this ulcer is going to hurt. So, how would you be able to tell whether this is happening in the stomach or the duodenum? I'm sure by now you've already have an idea. It's through this sphincter over there. When feeding begins, the sphincter closes and it opens approximately, an hour or so, depending on how much food you've eaten. But the sphincter closes. So, if this sphincter closes, it means that this acidic content isn't yet entering into the duodenum. And this acid, when it interacts with the ulcer, it's going to hurt. So either a patient will either tell you that this pain begins when I'm taking meals, or it begins a couple moments, a couple hours, a couple minutes after I have eaten. You are just thinking about the pyloric sphincter, this lower sphincter, the action of it opening and closing. So whenever you're eating, of course, the amount of hydrochloric acid being secreted increases. So if a patient tells you that the pain is experienced there and then, you'll be thinking of it being a gastric ulcer. The ulceration is in the stomach. If the action of eating reduces the pain through the action of this lower pyloric sphincter, If this sphincter closes, it means that the acidic content isn't entering into the duodenum. So you wouldn't expect pain to be there and then. But a few moments after, the whole churning, the whole digestive process begins and it has ended in the stomach, this sphincter opens and thereby exposing this acidic content towards the ulcer. And so this is why I was giving an example of, remember when salt was poured on a wound, say on your forearm, it would hurt. So similarly, in this case, you're thinking of it in a principle of acid, hydrochloric acid from the stomach coming towards that particular ulcer. So just to repeat, if a patient tells you that the pain is hitting, immediately they begin eating, you'll be thinking that this ulcer potentially is in the stomach. You have a gastric ulcer. If they tell you that the pain is happening moments after eating, the action of eating reduces the pain, you're thinking that, okay, this lower esophageal sphincter has closed, so this acidic content in the stomach isn't interacting with the ulcer in the duodenum. So most likely that would be a duodenal ulcer. So looking back at the question that we've been told, the pain improves with meals and then it worsens approximately 1 hour after eating. So automatically you'll be thinking, okay, this is a PUD, specifically it's in the duodenum. So just based off the history, what the patient tells you. The next thing that we're going to look at is what is potentially causing it. In this case, we have NSAIDs. So what is happening there? Think about it in this way. So homeostasis is something that I like to demonstrate oftentimes and not with a seesaw. So when we're dealing with the stomach is lined by mucus and it has got hydrochloric acid, similar with the duodenum having a mucus layer. So we have hydrochloric acid on one end of the seesaw and we have the mucus which is covering or lining the walls. So in order, if there's ever a mismatch between the two, potentially corrosion can happen and an ulcer happens and they like because of this hydrochloric acid. So if hydrochloric acid production is increased massively, example would be what? Zollinger Ellison syndrome, ZES. I might have butchered the pronunciation, Zollinger, something like that. So either the hydrochloric acid has increased or the mucus production has reduced. Either way, it leads the walls of the GI, in this case the stomach or the duodenum, exposed to the acidic nature of this hydrochloric acid. So how does NSAIDs, how does this happen? So when we're looking at the pain mechanism, we won't really look into it. We just know that there's what cyclooxygenase. You're dealing with COX-1, COX-2, but ultimately you're dealing with cyclooxygenase, and eventually prostaglandins are produced, and we perceive that as pain. So these NSAIDs, your ibuprofen, diclofenac, and the like, are dealing with this, the whole pain pathway. So if you can block these prostaglandins, it means that the pain will not be perceived. The pain won't be perceived while you have blocked this whole thing. Unfortunately, when we are looking at mucus production in the GI, these PGs, these prostaglandins, will be important for mucus production, which is lining and protecting the walls of the GI. So someone is taking NSAIDs, they've got a chronic condition. In this case, what were we given? We've been told that he has osteoarthritis, he's been using NSAIDs, he's increased the dose for the past 3 months. So these NSAIDs are working on this. If the PGs are blocked, it means that mucus is also blocked. If mucus is blocked, remember that homeostasis, you have your hydrochloric acid on one end and you've got the mucus on another end. So in this case, it's not that the hydrochloric acid has increased, but what has happened is that the amount of mucus has reduced. So by virtue of that, what ends up happening is more of hydrochloric acid, or rather not necessarily more of hydrochloric acid, but the weight, just think of it as a seesaw. So you've got less mucus, the hydrochloric acid can overcome it. And unfortunately, because of this whole erosion, this ulcer, this inflammation that's happening, it again leads to some more hydrochloric acid being produced. So to a certain degree, you have a twofold reduction in mucus production and increase in hydrochloric acid. So based off this, our diagnosis, this is a PUD, of course, in the duodenum. It's secondary to use of NSAIDs. Another thing to look out for in certain questions would be a woman of reproductive age, and she complains of having painful long periods which she normally treats with the same NSAIDs. So that's basically how this is happening. Another thing would be H. pylori, but in this case, we're not necessarily looking at that. So this PUD is secondary to the use of NSAIDs, and it's in the duodenum. And I think that would justify the 4 marks. What other symptoms can patients with this diagnosis present with? 5 marks. So you've got your bloating over there, and these are so PUDs oftentimes are not. In fact, this will be under upper GI bleeding. So remember that we are dealing with those that are proximal to the ligament of Treitz, and the symptoms are almost the same whenever bleeding is involved, which is a common complication when you're dealing with ulcers. So what can end up happening is that blood can go from either way, either end. You might have hematemesis. I always confuse it with hemoptysis. Hemoptysis, coughing blood. Hematemesis, vomiting blood, or blood in vomit and stuff. So yeah, they might vomit blood, hematemesis. Then melena, when you will have tarry, bloody stained, it's darkish. If it's fresh, you're thinking of hematochezia. So that's one thing that they may present with. That's another thing they may present with. Nausea is another thing. Vomiting is another thing. Bloating is another thing. Epigastric pain will be the commonest thing that they'll present with. But in this case, I think we're already told that there's epigastric pain, severe abdominal and epigastric pain. So you can write any of those other options as answers. Okay, then what is the most common complication of this patient's condition? Um, Possible causes and possible complications. Okay, so let's walk through this. The most commonest complication out of this, so let's say this is epithelium, and you have a corrosion happening which has led to that ulcer. You've got hydrochloric acid. This thing obviously can easily perforate. So perforation becomes one of the commonest um, complications. Now, unfortunately, this is the GI, right? So imagine there's a perforation. What else can happen? Bleeding. So hemorrhage is another thing that can happen. Whilst we're still there, remember that there's also air in the GI. It can enter through that perforation and you get air under the diaphragm, which is what? Pneumoperitoneum, which of course hates be an emergency. Then we're still on this. Remember that the GI isn't sterile. You have organisms, you've got bacteria within the GI. It can enter into the peritoneum. What can end up happening? Spontaneous bacterial peritonitis. Again, you've got bacteria and other things. It can enter into the bloodstream and you end up getting septicemia. So just kind of think of it in that way. Other things that can happen if there's chronic vomiting, you get electrolyte imbalance, and at the level of the heart, you might get arrhythmias and so forth and so on. Fever. So just think of it as a story. So common as complication, one which is the most common, we said the perforation, possible causes of this. Okay, so we haven't talked about that. Then list possible complications that can this diagnosis, these possible complications that this diagnosis can lead to will be the same things: hemorrhage, spontaneous bacterial peritonitis, pneumoperitoneum, septicemia. Just think of it as a story. There's a perforation, blood, this and the like. Okay, then possible causes of this diagnosis. When we are looking at When we are looking at these PUDs, potential causes of these PUDs, so you have your H. pylori infection. You have your H. pylori infection being a common cause. You've got chronic use of NSAIDs, like this question alluded to. You've got emotional stress being one of these things. You have spicy foods, and the spelling, smoking. Remember, smoking's best friend, chronic alcoholism. Then ZES, remember the Zollinger Ellison syndrome, something like that. Anyway, what's happening with this ultimately is that it will lead to an increase in hydrochloric acid in the acids that are secreted. So because of that whole thing, remember homeostasis, you want to have a balance between the amount of acids that are secreted and the mucus which is lining the walls of the GI. So a mismatch in that would be bad. Then remember you said that you are also given omeprazole, right? So that's serving as a proton pump inhibitor, and it will help reduce the amount of hydrochloric acid, trying to reach that homeostasis thing. So this is just a matter of homeostasis. So the take home message here is to remember that you want to kind of localize where this PUD might be, whether it's going to be in the stomach or it's going to be in the duodenum. The feeding patterns, pay attention to the feeding patterns. When does the pain worsen? When does the pain get better? That will give you a brief understanding potentially of where this ulcer might be. It's made some sense, yeah?